السلام عليكم.
وعليكم السلام دكتور، كيف حالك؟
أهلا وسهلا دكتورة نانسي، كيف الصحة؟ إن شاء الله بخير.
تمام مشتاقين، الله يخليك.
كيف الأمور صارت أحسن إن شاء الله؟
تمام الحمد لله.
الحمد لله رب العالمين. يلا هيك حظنا حلو، حنشوف حضرتك مرتين بشكل قريب.
الله يخليك، أنا حظي الحلو.
تسلمي. المحاضرة الثانية إن شاء الله حتكون يوم الاثنين إن شاء الله، اللي هي تبع الكيميكال بيرنز إن شاء الله.
إن شاء الله. أوكي. إحنا we still have 6 minutes, yes؟
تمام تقريبا.
تمام، بعمل بس some touch ups.
أوكي. بدنا دكتورة نبلش نحضر إن شاء الله للمور أدفانس
second phase. خليني بس
سيريز إن شاء الله.
إن شاء الله.
بجهودكم إن شاء الله. تسلموا الإيدين، شكرا جزيلا.
بالعكس، شكرا على الفرصة، يعني إنه to be part of this platform. إن شاء الله إنه تكون مفادة ناس كثير، يعني I think.
نعم.
الموضوعات
عفوا سوري، تفضلي حضرتك.
لا إنه الموضوعات كثير مهمة، يعني عم بيجيني
نعم.
فيدباك إنه كثير ناس عم تستفيد صراحة.
صح، هذا الشيء اللي كنت رح أقوله، وخاصة إنه إحنا مشينا معاهم من البيزك نوعا ما وباتجاه الأدفانس. الناس متعطشة حقيقة لموضوع البيزك مثل ما هي متعطشة لموضوع الجراحة، لأنه أحيانا أنا بجوز ما أكون مثلا فرضا يعني سبيشاليتي تبعي بجوز ما تكون كورنيا، إنه والله أنا أعمل أدفانسد كورنيال سيرجريز، بس بنفس الوقت أنا بالعيادة تبعي أنا ممكن أشوف كثير أشياء بدها بس بيزك مش أكثر يعني.
تمام. that's correct. حتى
في
كمان
نعم.
في كمان يعني مرات الواحد بيكون كثير انشغل بالسبيشالتي تاعته أو بهز اون ورك، في أشياء معينة بيفكر إنه إحنا وصلنا لهذا الاند بوينت اوف تريتمنت وخلص. sometimes eye opening هدول المحاضرات، إنه yes I can refer, yes I can do something. حتى طريقة الكونسلنج للمريض اختلفت، إنه والله في something that can be done. ف cross reference between specialties كتير مهمة، يعني مش ضروري يكون واحد specialize بشيء معين، حتى بالسبيشالتي نفسها تقدر يعني في ناس بيكونوا متخصصين بجراحة معينة حتى في القرنية، فكتير مهم. eye opening.
صحيح. هلا مثلا في الجلوكوما سيريس نوعا ما يعني صار فعلا اي اوبننج على كيف الواحد يقرا الفيجوال فيلد، كيف يقرا الاو سي تي، كيف يشوف الاوبتيك نيرف. حتى تخيلي بس الاوبتيك نيرف بحد ذاته كمان هذا يعني كان سيشن فول سيشن. ف صار حتى الواحد يعني لو انه بجوز بالمكان اللي عم يشتغل فيه بجوز ما يكون في جلوكوما سبيشالست، او بالاريا كلها اللي عم يشتغل فيها ما يكون في جلوكوما سبيشالست، وبالتالي هو صار بامكانه انه ياخذ قرار بشكل افضل لين ما انه ممكن يحول المريض ل سب سبيشاليتي بمكان اخر او باريا اخرى.
لا شك 100%. دكتور محمد حسني رح يكون معنا اليوم. أنا ما انتبهت للإيميلز، كان عندي crowding
He
شوي.
didn't reply.
He did not reply.
He didn't reply. No.
I know Christopher Liu is going to Russia.
شفته على البوست اللي حطوه. الحمد لله الدنيا هلا back to normal life. The travels
almost yes. الحمد لله.
ولو انه هذا اصابنا شوي بالكسل، وصار الواحد بيقول طيب ما اونلاين كله عم ينحل، ليش لحتى الواحد يسافر؟ يعني مثلا انا ما حروح على الاسكرز.
والله هو يعني مش كثير مفتوح حتى الفيزا، يعني مش كثير مفتوحه حتى فيزا الاسكرز، يعني مش يعني معظم اللي رايحين مقدمين توكس هيك اللي شفته يعني. هو مرات
او عندهم شنغن بالاصل بتكون
احنا
موجود
كمان او معه يعني اوريدي يعني في دينايل شوي انه والله فتحت، يعني هيك الواحد هيزيتنت برضه. بس الحمد لله يعني everything is going back.
الحمد لله.
أنا عندي مشكلة إنه هاي الزوم سكرين عم بتغطي السلايدز، مش عارفة كيف تمينيمايز، المفروض بالفيو بس ما عم بفتح معي. مش عارفة إذا حدا من التيم
حضرتك عملتي شير؟ عم تعملي شير حضرتك؟
لا لسه ما عملت. أعمل شير.
ايه اعملي شير لحتى تقدري تشوفي السلايدز.
اوكي
تمام. we can see now.
أنا قصدي على الويندو مش قادرة أعمل له مينيمايز. لحظة شوي. تمام I'm fine هلا.
إيه تمام مشي الحال الحمد لله.
We have 1 minute ولا we can proceed. احنا live streaming. الموضوع على فكرة مو سهل أبداً. ما أظن.
إيه نعم.
ولا أخفيك إنه يعني أنا I was surprised إنه this is my talk. ما كنت حاسبته يعني.
والله.
لا كنت ناسي إنه my talk هذا في UK يعني Peripheral ulcerative keratitis. بس stimulating إنه الواحد يرجع يقرأ مرة ثانية و to look into the patients يعني how we're managing them.
تمام الله يعطيك العافية.
الله يعافيك.
So we can start. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Welcome everybody to this session, session number 7 in the corneal series with our eminent speaker, Dr. Nancy Raqad from Jordan. And we missed her last time because of unforeseen circumstances. We were supposed to learn from her last time the chemical burns, but we are going to learn the chemical burns just after 3 days from now on Monday. So be with us. Today we will enjoy, of course, listening to her with a very interesting talk, My Waist Hurts. So the stage is yours, Dr. Nancy, please.
Thank you very much for the introduction. I'm happy to be back again. Today we're going to be talking about a very important topic, a topic that's overseen in ophthalmology, not only in cornea. And the title "My Waist Hurts" is very descriptive of this pathology or disease. لأنه the hallmark of this problem is pain. The second thing about peripheral corneal diseases is not being a cornea, ولا إنه it hurts. It's the periphery. And naming it periphery has a very important indication, because the periphery has so many properties that's different other than the central clear part of the cornea. أول شيء the peripheral cornea هو اللي عم نحكي عنها هي between the central 50% and the margin. Let's not forget that the margin or the limbus is highly vascularized. There is vascularization, vessels, and lymphatics along with it. So this margin or limbus is adjacent to it. There are stem cells in the vicinity. There are Langerhans inflammatory cells. So any disorder that affects these or this area affects the cornea in a very obvious way. Continuing to say, why is it peripheral? Now, the blood vessels and lymphatics, they provide arm of the immune pathway. When we talk about immune, we're talking about cytokines, protoglycanase, collagenase enzymes, or the degradation enzymes or the lytic enzymes that can be secreted when inflammation pursues. As we mentioned earlier, the concentration of Langerhans cells around the corneal periphery is more. There's more also concentration of complement factors and immunoglobulins, especially immunoglobulin IgM, IgG, and IgA, and they are present in high concentration around the corneal periphery. So we can look at the corneal limbus as a reservoir, as it is a reservoir of the stem cells. At the same time, it is a reservoir of inflammation and inflammatory mediators. We can classify peripheral corneal diseases into two groups. And I like to look at it in two different views. First, limited ocular causes and systemic causes. Now, the ocular causes usually are not as prominent as the systemic causes. We all look at PUK as a systemic disease, but the ocular cause cannot be overseen. Some cases, and we can also divide them into infectious or non-infectious. As I know, the list is very long and no one can just memorize all the list of causes for peripheral ulcerative keratitis, but it's important to catch at least 10 causes from all the list of ocular and non-ocular. Ocular causes, the infectious causes include the staphylococcal bacterial infection, streptococcus, and when we talk about staph, we're talking about blepharitis. Blepharitis can initiate peripheral ulcerative keratitis. One of the very important causes of peripheral ulcerative keratitis is herpetic infection, and we're not talking about herpetic keratitis in the stroma, we're talking about herpetic surface, herpetic epithelial keratitis. The zoster is also a very important provocative for peripheral ulcerative disease, acanthamoeba keratitis, and fungal to a lesser extent. The most important infections to rule out in a patient who has peripheral ulcerative keratitis is the staphylococcus. So you look at the limbus, you look at the eyelids, and you look at the margin, and you examine for any kind of anterior blepharitis, and you look for any signs of herpes zoster or herpetic infection. These are the most important to eliminate in a patient you're suspecting an infectious cause of his PUK. Now, the non-infectious is a long list. Usually, we do not exclude the systemic manifestations and go to the non-infectious ocular until the very end, especially with the idiopathic. Acne rosacea can provoke it, but please remember that acne rosacea also causes blepharitis, and the blepharitis, they do provoke PUK. Moran's ulcer, I will discuss this later, traumatic or post-surgical, exposure, neurophylactic keratopathy, marginal keratitis. Again, marginal keratitis can be a cause of toxins produced by the staphylococcus from the lids. So we're going again into a circle from infectious causes, contact lens use because of the hypoxia and the injury and the microtrauma to the cornea, and nutritional deficiencies. All these together, they lead to micro-injury or trauma to the cornea, and thus triggering of the inflammatory cascade in the around the limbus, and this is what causes the peripheral ulcerative keratitis. The systemic list is very long, and this is just a tip of the iceberg. But we can, again, say the systemic can be infectious or non-infectious. The infectious systemic manifestations are very, very rare, but one of the most important systemic infections that might provoke PUK is hepatitis C. So we have to keep in mind that hepatitis is an important and prominent cause of PUK in an otherwise non-diagnosed cause for PUK in a patient. And the more often is the non-infectious cause, systemic cause of PUK, and we can divide them into a collagen vascular disease or vasculitis, and these are more important, more aggressive, and more commonly encountered. And we're talking about rheumatoid, vaginal granulomatosis, polyarthritis nodosa, Sherk-Strauss syndrome, lapsing polychondritis, lupus, scleroderma, and giant cell arthritis. And as you can see, giant cell arthritis can cause PUK in two ways. As a vasculitis, and this is usually associated with necrotizing scleritis, or as an autoimmune response to giant cell arthritis. So it provokes PUK in two ways. Sjogren's, OCP, inflammatory bowel, Crohn's, sarcoid, all these also they play a role in as an infectious systemic or autoimmune causes or association with peripheral ulcerative keratitis. So the pathophysiology, to sum it up, is simply put an immune mechanism, whether it is a humoral and cell-mediated immunity involved, whether it is an autoimmune reaction to antigens in the cornea, whether it is a hypersensitivity to exogenous exposures, such as in the case of marginal keratitis or staphylococcal blepharitis, or is it an immune complex deposition? All these, they play in one direction, which is triggering an immune response in the vicinity around the corneal limbus and initiating the oozing of inflammatory mediators into the cornea. So why does the cornea ulcerate? The cornea ulcerates because of this inflammatory cascade that's been turned on. And how progressive and how aggressive is the inflammation that's occurring around the vicinity? This will determine how ugly will be the ulceration or the guttering or the undermining of the cornea. You see inflammatory cells invading, you see the blood vessels that were just pushed away by the limbus stem cells from the cornea, just invading the limbus. You'll see the angry vessels, you'll see hyperemic conjunctiva, and you'll see oozing of lytic enzymes that are activated. We're talking about collagenases and protoglycanases, and they eat up the attachments in the corneal desmosomes. And the vessels and the lymphatics also will, that are in close proximity, will bring in the inflammatory cells, neutrophils, and all the immune mediators, the cytokines, will just assemble there. And the end result will be keratolysis of the corneal stroma. It's very important to know it is keratolysis. So the cells, they just die, they are necrotized. And as time goes by, ulcer or thinning ensues. So simply, peripheral ulcerative keratitis is a destructive inflammatory response of the cornea. So if we know this for sure, I think this will make any picture of peripheral ulcerative keratitis explainable to any ophthalmologist. And it's, let's say your main reason is not to diagnose which caused this, as long as you know this is an inflammatory destructive phenomena that has to be stopped as soon as possible. How do they present? They present in so many variable ways. They can present according to the underlying cause, of course. If it's an infection, they come with lacrimation, red eye, pain, photophobia. You might see infiltrating the cornea, and you might not notice the ulcerative keratitis until later. There might be hypopia, these are the signs. And sometimes it might be very subtle. There might be very minimal pain. And the only thing is that the change in vision because of some cells in the AC causing a blurring or floaters. It might be only a red eye because of the conjunctival hyperemia. Sometimes it is really painful if scleritis is associated. Sometimes it's foreign body sensation or grittiness. Sometimes it's photophobia or decreased vision because if the destruction is so severe, astigmatism might happen, or even the destructive mechanism can encroach into the central part of the cornea and just decrease the vision. This is until we go into the more serious complications. So what do you see? What are the signs? Usually it is a crescent-like erosion. Sometimes it's not always straightforward. You might see patches of undermining of the cornea in the periphery that might coalesce as the disease progresses. And there's overlying epithelial defect, and this is a very important sign to look for, an overlying epithelial defect. There's usually accompanying conjunctival or scleral inflammation with or without vascular inflammation. And this is an important also point in order to differentiate between this and Morin's ulceration. There is thinning, absolutely. Sometimes there might be an infiltrate according to the cause. If it's an infection, if it's a contact lens wear, there might be infiltrate. And the clinical disease severity, we can predict it according to the depth of the ulceration. Yani, we can assess if it's progressive and how bad it is. We can allocate 4 stages of the disease. So stage 1 is stage 0 is if there is no thinning at all, just hyperemia at the limbus. Stage 1 is when it is only 1/4 from the thickness of the cornea, the ulcer size. Stage 2 is when it is 50%, stage 3 when it is 75%, and stage 4 is the melting and the complete destruction of the cornea. And the conjunctival inflammation also is stage from 0 to 4 according to how many quadrants. Now, scleritis is a very important differentiating element, and we have to differentiate between scleritis and conjunctival hyperemia. And because scleritis, especially if it's necrotizing, this means it's a very serious disease, and this will affect our management plan that I will discuss later on. If it is associated with the uveitic cause, we will see cells in the AC, as I said. And if it's infectious, you might see also hypopyon in the AC. Now, we asked...
So, Dr. Nancy, so if there is hypopyon, definitely it is infectious. We cannot see hypopyon in uveitis, autoimmune, for example.
Yes. Now, if it's it could be a sterile hypopyon, but this is very unlikely. You have to add up to the other. If there's an infiltrate and a hypopyon, this is for sure an infectious cause. Unless it is the herpetic, you see a hypopyon, the herpetic keratitis, and the cause is not infectious, it's an inflammation. But the cause of the inflammation is an infective agent. You see what I mean? Now, hypopyon is an inflammatory response. Sterile hypopyon, you can see it in cases of uveitic causes, but uveitis per se does not cause PUK. It's what causes the uveitis. So it's an infection is more common to cause PUK. If it's a herpetic infection, this is an inflammatory response, we know, but the causative agent is an infection.
Okay, clear. Thank you.
Now, is it dangerous? Is PUK a dangerous thing? Absolutely, it is. It's an emergency because it can spread circumferentially and it can cause contact lens cornea. As we said, it squeezes the cornea so small, encroaching into the center, and this will endanger vision. Also, it might cause perforation. It depends on the cause, and if there's a fulminant inflammation, cataract might also be noticed, and glaucoma if there is also a destruction or inflammation in the trabecular meshwork. How we diagnose it? It's very important to know or to remember what Shakespeare said, that when sorrows come, they come not in single spies, but in battalions. يعني المصائب لا تأتي فرادى. فA PUK usually does not come alone. PUK comes with a lot of superimposing things. So you have to have a high index of suspicion, even if it was a small ulcer in the periphery. And this is why we always say to the junior doctors or the residents to differentiate between an ulcer that is in the middle of the cornea, which is usually an infectious cause, and an ulcer that is in the periphery of the cornea, which is usually an inflammatory cause, an inflammatory response. And sometimes I say when vessels they invade the cornea to heal an ulcer in the middle, this is a very good sign. Although we don't like to see vessels coming encroaching with the cornea, but in an infection, the vessels coming to the ulcer, this is a very good sign of healing. But in cases of peripheral ulcerative keratitis, if you see an ulcer that is in the periphery, this is a very bad sign, and you should not pass it as an infection per se, and the patient goes home. So you have to have an index of suspicion, and you have to elicit all the signs or the symptoms through the history. History taking is a very important determinant of the success of your treatment and diagnosis in peripheral ulcerative keratitis, because it's usually not a disease only of the cornea, it is a systemic disease manifested in the eye. So history of trauma, of any surgery in the eye, especially cryotherapy if done, any chemical that's been used for in the eye, any contact lens wear. We're now talking about the ocular causes, any infection in the past, any oral tablets that the patient takes for hepatic eye disease, for example, any history of zoster, and then you elicit the systemic diseases. You ask about pain in the knees, pain in the knuckles of the fingers, any problems in the back, all the systemic disease that you can elicit. And then after this, you go to the examination. And the examination is very important to look at the patient as a whole, and you just not look at the eye as a single organ. So you examine the eye properly, trying to elicit any local cause of PUK. And then you go and look at the hands of your patient, ask him to raise a hand, grab, shake hands. Shake hands in Corona time now, just maybe the Corona punch, wave his hand to see his fingers for botany deformity. And we always see this in the clinic. Ask about knee problems, deformities. Look at the nose if it has an abnormal deformity or configuration, because 50% of cases are associated with systemic disease and mainly rheumatoid arthritis. Rheumatoid can be elicited in almost 50 cases of PUK patients diagnosed in the cornea clinic. Not to forget Wegener granulomatosis, systemic lupus erythematosus, relapsing polychondritis. And I know as ophthalmologists, we cannot just memorize all the medical terms and medical diseases that can pour into PUK. And I think this is the main reason we did not go into medicine, but sometimes we have to go back and have a list in our minds. And it's okay to have a list in front of our eyes, actually. So it's very important. This is what I tell my fellows and residents is you see what you look for. If you don't have anything in front of your eyes to look for, even if you cannot grab the information, you can keep this particular slide or this particular table and just put it in front of you on the desk in the clinic. And just if you see a patient with PUK, you can just mix and match and see which one fits into the patient's description. So if a patient has a saddle nose deformity, then think of Wegener granulomatosis or relapsing polychondritis. If he has an auricular pinna deformity in his ear, think of relapsing polychondritis. If he has nasal mucosal ulcers, then Wegener is a most probable diagnosis. Systemic lupus SLE erythematosus, you have to look for the oral, lip, or tongue mucosal ulceration. Also, a butterfly or malar rash, alopecia, hypopigmentation in the scalp or face. These are signs that usually direct you into SLE. Giant cell arthritis, we all palpate the temple for giant cell arthritis if it is suspected, and especially if the patient came back with a high ESR or CRP and elderly, and just there are jaw claudication or temporal paresthesia. Now, rheumatoid arthritis, this is something cannot be missed. The patient with the rheumatoid, and usually it's an advanced disease. You can see the botanier deformity, the swan neck deformity in the fingers. All these, you can see them and elicit them in the hands. And you can just ask the patient, do you have a rheumatoid or not? And in 80% of cases, the answer would be yes. There might be subcutaneous nodules in the arms and the legs. And you ask generally about arthritis. Sometimes you have a patient who is young and presents to your clinic with a picture of PUK that comes in one eye. Usually, patients with systemic disease, they come with bilateral peripheral ulcerative keratitis. One eye might be more prominent than the other, but in general, they come with bilaterality, not necessarily symmetrical involvement. In ocular causes, it is usually, or undiagnosed systemic diseases, maybe in the beginning of the disease, usually they come younger at age, and they come unilateral, not because they are unilateral, because you might miss the eye which has milder symptoms and focus on the eye that has the more prominent symptoms. So it's very important if you see a young patient who has a unilateral PUK, not to eliminate, even with history, the systemic cause, because you can discover a systemic cause and save the patient from a long journey of systemic complications. What are the laboratory tests that you should ask for in patients with peripheral ulcerative keratitis? It's a long list, but initially you have, if you suspect this is an infection, it's important to swab the eye for infection. Now, most of the infection causes are, as I said, staph or strep. They are gram-positive, so you can cover them with the empirical antibiotics. Otherwise, if they're not improving, you can just swab the eye for a culture. Baseline CBC blood count, because if you needed a systemic immune suppression, you need to have a baseline CBC. ESR is mandatory, and CRP. Rheumatoid factor, as I said, it comes 80% positive in patients with rheumatoid arthritis. The ANA, which is anti-nuclear antibody, is for the rheumatoid arthritis specific and the SLE. C and K, and I forgot actually what does that stand for. I think anti-cytoplasmic nucleoside, something like that, for the Wegener granulomatosis. ACE, which is angiotensin converting enzyme, is very specific for sarcoid, although it's not mandatory to be a positive. Hepatitis C, this is not to be hepatitis C surface antigen. If you're suspecting or you excluded all the all the problems or all the pathology that might cause the PUK, and you wanted to check if there's a hepatitis element. Chest X-ray and sinus CT is for the Wegener granulomatosis, and it's very important to work under teamwork. Now, PUK is not a disease of the cornea only. It is a disease that's covered by a cornea specialist or anterior segment specialist, but it is managed by a lot of specialties. It's managed by the cornea, it's by the general ophthalmologist, and also with the medical immunologist and the rheumatologist. It's very important to keep a teamwork managing these patients, because these patients are long-term patients. They will come with good days and bad days. They will have a long-term monitoring duration for disease management. And you need the rheumatologist and the immunologist and the lab technicians in order to monitor the doses for the systemic immune suppression drugs that you need to give for these patients, if needed.
Dr. Nancy, a question,
Yes.
please. Now, if you go back to the list for the laboratory, we may face some patients who cannot afford this list expenses, and they, for example, they cannot go to public hospitals for any reason. So if you want to choose the most important 5 tests out of this list, what are you going to order?
Okay, this is an excellent question. Thank you. Now, the most important test is your suspicion. So rely on your suspicion. If the patient tells you that he cannot afford this, go back to the list where we set this one of the clinical findings and try to elicit it more meticulously. Spend some chair time looking for anything that directs you to which disease entity you want to highlight or put your finger on. Now, if you find the patient that has a boutonniere deformity in his fingers, it's very obvious this is a rheumatoid arthritis patient. So you might skip the list. You just ask for a CBC. You don't have to swab. A CBC ESR, rheumatoid will be 80% positive. You don't need this. And you can just liaise with the rheumatology and immunology. You can skip the other list. Now, the problem is when you have no definitive diagnosis and you want to give a patient a very heavy protocol of immune suppression and you want to justify it. Then you go with the ANAs and that CNK and the angiotensin converting enzyme. Although sarcoidosis sometimes can be accompanied with other signs like the alopecia, the ACE inhibitor, and sometimes just CT can elicit this. But if the most 3 are the ANA, CNA, and ACE, in addition to the CBC.
Fantastic. Okay. Thank you very much. Yeah, great. Thank you.
So it's very important, if you could not put your finger on disease integrity, to start treating right away. It's not important. Now, diagnosing is something you would want to know later, but what you want to do is don't send the patient home immediately, reassuring him. You have to start treating right away. Because sometimes the patient might come with a very dormant, kind of very smooth disease phase and progression, and you see no change over weeks. and suddenly the cornea perforates, because sometimes the immune system just lays like a roller coaster and it just spikes and goes into a storm of immune response, and this degrades the cornea suddenly. So what you need to do, you have an ulcer, and the ulcer is due to an inflammatory mediators that are eating it away. What you have to do is, first, you want to lubricate. And the reason of lubrication, not because you might have a Sjogren's or Sjogren's syndrome or a rheumatoid arthritis, that because of keratoconjunctivitis sicca that might ensue and make the problem more severe. No, this is not the reason why we lubricate a patient with peripheral ulcerative keratitis. The main issue is that we want to dilute the inflammatory mediators that are swimming in the vicinity of the cornea by putting more water into the area. So the more water you put, the more you wash out the effect of the inflammatory mediators, and the more you minimize the effect on the cornea. So this is the first thing. The second thing, the lubrication enhances the healing by making a layer over the corneal surface and mediating the stem cells and the epithelial cells to bridge the gap and reach the area of epithelial defect. So this is the main issue with lubrication. Now, if you have an infection, it's very important to kill the bug. And as I said, if you don't...
Dr. Nancy, sorry for interruption.
No, please.
Now, actually, it is an amazing point why we use the lubricant here. Yes, not only to enhance reepithelialization, but for dilution. I learned it from you now. Now, do you have any preference of lubricant composition, or let's say, should we avoid any composition? For example, we know that when there is an inflammatory process, it's better to avoid hyaluronic acid because it is an acidic. And maybe we avoid it just until we settle down or we calm down the inflammation within a couple of days, then we can move to the hyaluronic acid. Is it the same thing here, or is there any preference?
Absolutely, this is an amazing question. Now, let me put it this way. Avoid ointments, avoid viscous gels, because you don't want to overweigh the cells that are bridging the gap to reach its site. This is the first thing. Second thing, avoid anything that might add on the inflammatory response. Avoid anything that has preservatives, because now you're increasing the problem. So use preservative-free drops as much as possible. Avoid use a low concentration of hyaluronic acid if you want to. I would prefer the drops that can be used after a PRK, for example, a surface ablation surgery. Drops that might have some vitamin C in it, or ginkgo biloba, or any component that will help in healing. But still, the main issue is that it is preservative-free and it is not viscous or gel shape. It's very important to be more aqueous. So you choose the aqueous kind of artificial tears, not the viscous, not the mucin-like, not the ones we use to treat mammary gland dysfunction because of mucin deficiency, not the one we use to treat a problem in the oily layer of the cornea. Treat it as if there is a deficiency in the aqueous layer. We're pouring water. The more water you put, the better effect you get. This is how we look at it.
Yeah, very nice. Thank you very much. Amazing lessons today.
Okay, so if it is an infection, and the infection usually it just you can just spot an infection if there's an infiltrate, stromal infiltrate and whitening, plus minus hypopion, localized to one side, history of trauma with something. You need to kill the bug. We said the infection that elicits a PUK usually is a staph or strep. And it is usually, it can be covered with monotherapy, Vigamox, Zemaxid, any of the fluoroquinolones for 4th or 5th generation. Usually the infectious PUK, you can see a response very rapid as compared with an inflammatory peripheral ulcerative keratitis. Now, a very important point to discuss, and we always talk about this, if you suspect PUK in a patient who is already on topical steroid for any reason, for vernal catarrh, for dry eye, for anything, post-surgery, you have to keep the topical steroids at bay because they promote progression and proliferation by inhibiting the collagen formation, خاصة بالvasculitic causes such as Wegener, especially in Wegener granulomatosis. There's one or two things that I would use a very mild steroid on the cornea. I'll tell you about it later as we discuss the treatment. But as a general rule, if the patient uses topical steroids, stop them right away. Don't think of it as an inflammation that you need to pour in anti-inflammatory at the same time. It's also important, and this has been going all around, to stop any and not to think of giving the patient any non-steroidal anti-inflammatory drops, because you are killing the patient or killing the cornea of the patient. Eventually the patient in no time. The patient will have pain-free periods of corneal perforation and he will come happily perforated. So this is the only thing that you would change. So avoid steroids, and I'll tell you the rationale of using steroids and avoiding it, and avoid non-steroidal anti-inflammatory drops. Nothing anti-inflammatory on the cornea. Use all the anti-inflammatory medication you can systemically, but not on the cornea. So as we said, the mild steroid or any steroid you use, it just stops the collagen formation, and that we need to build up structure, and so it will delay the reepithelialization and strengthening of the corneal tissue, and will cause just progression and worsening. You can give an anticollagenase, which is a doxycycline or tetracycline. We know tetracycline in pregnant women and children under the age of 10 or 11 are not advised. You can use doxycycline. Actually, I like doxycycline in all patients. It is a magical component of, it's a magical friend for the cornea. So use doxycycline, 100 milligram, for as long, you can use it as long as 6 weeks, and you'll be fine and safe, as long as the patient can tolerate it. But tell them to avoid sunlight unless they want to tan, to avoid milk and milk derivatives in order to make sure it acts properly. Now, doxycycline and vitamin C are very important for the healing of the stroma, for keratocytes. And you can see the effect in like 48 hours in front of your eyes. So this is combination of doxycycline and vitamin C is very important for any ulcer and for any stromal necrosis. And I do tend to use this. If there is a systemic association, and you can see this, like if you see the patient having rheumatoid arthritis, and you see that right away, it's very important. If you see the patient he has a large peripheral ulcerative keratitis, to start systemic steroids. Okay, what kind of systemic steroids? Now, I come from a school where I believe in the pulsed methylprednisolone, because oral therapy needs some time to produce any effect. If you go over 14 days, you need a tapering response, and you cannot guarantee that after 14 days, you'll be there in the clinic and you'll just taper it the way it should be. So, and the patient might go into a long tunnel of complications. So I like it 3 days, pulse therapy, IV methylprednisolone. You can choose between 500 or 1000 methylprednisolone. You can use it in 200 cc normal saline in half an hour. And you can even not see the patient for 3 days and just come and check him after 3 days. And this is, in most of the cases, a magical combination. So I vouch for the pulsed methyl, except if you have other contraindication, like the patient cannot be admitted to the hospital, or there are no beds, or the patient he needs to be on a very low dose of steroids, so you'd go with the oral 1 milligram per kg per day. So you would choose the oral treatment. Otherwise, go for the three days of pulsing, the methylprednisolone, and you can guarantee satisfaction in 80% of cases. Now, beware of the prolonged use. And what I mean prolonged use means keeping the patient for 4 or 5 weeks on steroids orally without monitoring the response. Sometimes patients, they can come in, for example, osteoporosis in no time. They might come with necrosis of the head of femur, osteoporosis. Sometimes they might come with fracture, compression fracture because of the osteoporosis. And this comes usually in the young rather than the old, because a sudden osteoporotic change in the bone will just cause a dramatic response in the body. And this is why, if you think that the patient is not improving on the systemic steroid that you're giving, you have to shift straight away to the systemic immune suppression. Before I leave to that, do you want to ask any question, Dr. Mazen, about the management? Because I want to talk about systemic immunosuppression.
Yeah, thank you very much. Actually, the concept of using the steroids is still not clear. So let me assume we have a case now. And the patient came with peripheral infiltrates, no epithelial defect, and no thinning. And let's assume that I started steroids with this patient because I assume that it is okay, sterile. Now, the patient comes after a couple of days with thinning and epithelial defect. So let's say it is grade 2. So we can say that 50% of the stroma is thin.
Yes.
What shall I do?
Okay, this is excellent.
Stop the steroids?
Yes, definitely. Now, what you described earlier is a marginal, if I saw infiltrates in the margin of the cornea, I would think this is a marginal keratitis. I would look at the limb, at the eyelids and see if there's an anterior blepharitis. I would treat as marginal keratitis, and I would give steroids, which is the hallmark of treatment, is steroids and some antibiotic, mild antibiotic. Now, if I see that the patient comes after 2 days with a epithelial defect and undermining or ulceration, I know epithelial defect is something, and stromal keratolysis and undermining and thinning of the stroma per se is different. So we're talking about we have to look into the stroma, forget the epithelial defect. Epithelial defect comes with so many disease entities. Concentrate and focus on the stroma. So if the stroma is thinning and there's a guttering or between the limbus and the stromal guttering, there's a furrow, there's a زي خندق, okay? You have to think this is a peripheral ulcerative, this is an ulcerative, this is a destructive inflammatory response, and I have to stop the steroids immediately. Now, if I'm in doubt, until I diagnose this properly, I can make the steroid once daily, very weak steroid like fluoromethalone. So fluoromethalone once daily, if you are in doubt and still the picture is not very clear and aggressive to you, but put it in mind that you shifted from a patient that only needs topical treatment to a patient who might be a PUK, and you're going to work on another mechanism, and you start him right away on systemic steroids until you see what's going on, and you see him next day. If the systemic steroid is doing a good job, you stop the FML or the fluoromethalone immediately.
Okay, fantastic. And what about the Wagner?
Now, the Wagner grammatosis, if you suspect it, if you see all the features of Wagner grammatosis, or the patient comes to you maybe undiagnosed with a peripheral ulcerative keratitis that's very subtle, not let's say +1 only degree of ulceration, just a mild guttering that looks like an arcus senilis, and you did not, you could not elicit this as a complete guttering or thinning. But the patient comes with a saddle nose, and he has this referral with a long list of tests that he has, and he has a positive test for Wagner grammatosis or a CT or chest X-ray. Then what you do is you stop any steroids, no matter what the case on the cornea is happening immediately, because in no time he will perforate. This patient will perforate in no time, and you must be aware of this.
Okay, great. Thank you very much.
I think some people are.
Yeah, there is a question. Yeah, there is a question. If you allow me to say some minor points. PUK in elderly patients, especially rheumatoid arthritis related, admission is necessary due to the fact that the patient often have difficulty installing the drops. So this leads us to the question, when do you admit the patient of PUK?
I always admit any patient that I need to give IV methylprednisolone, whether it is elderly or it is a young. Any patient for pulse therapy, I admit him or her. If they cannot be admitted, then they come on a daily basis to take the pulse methyl, and at least stay in the hospital for 4 hours to monitor them. They can go back and come back again next day for the second dose. So I prefer systemic admission to any patient who would take a pulsed treatment, especially the elderly.
Yeah, so only for pulse, but apart from that?
No.
Okay. Also, Dr. Muhammad says also consider eye protection, like eye shields.
Oh, yes. These are the things that you need to tell the patient for that the cornea is very thin and fragile. Don't rub your eye. Some people or some practice, they place a contact lens on the cornea. I do not prefer this because a contact lens the edge of it, as it moves, it might just endanger the thin area and cause more damage. So I prefer not to use a contact lens. Unless the cornea is very, very thin and you want to bath the eye with lubrication, then you can just use a lens. And I prefer it to be a large diameter lens in order to cover the whole area of cornea and sclera.
Yeah. Now, before I read the question of Dr. Muhammad, now, do you lower the IOP just to avoid perforation in high-risk cases? For example, giving some drops or maybe acetazolamide orally?
Fascinating question. Now, I don't lower the IOP anticipating a perforation, but I do lower the IOP if it is just impending. Like if I have patients with a real perforation that's plugged by an iris, let's say, or a descematocele that's a very thin, I do use, even if the intraocular pressure is low, I use timolol drops, which is very inflammation friendly. Avoid anything that's prostaglandin analog. Avoid acetazolamide drops because they are they do provoke inflammation more. So avoid these, abstain from these drops. The most friendly IOP lowering agent is the timolol or the beta blocker. So I do use it if I feel that the eye is on the verge of perforating, or if it is already perforated and we're waiting for it to re-epithelialize or do any kind of surgery. I want to say something. Usually the perforation is not that common in peripheral ulcerative keratitis compared to perforation with infective keratitis. You see infective keratitis perforation associated especially with herpetic keratitis more often than you see with PUK. For many reasons. First, PUK is usually a stromal keratolysis. You need, and you're talking about the periphery, it's a 0.7 millimeter of thickness. So in order to eat off all this, you need a very aggressive inflammatory response. What accelerates this is the steroid drops or non-steroidal anti-inflammatory drops that you might use, especially if the patient has a Wagner granulomatosis. Otherwise, even if you reach like +3 guttering, it's not that, you will not see that perforation unless the patient has an infection like a herpes, or if it's a microtrauma with rubbing the eye or sleeping. That's why I prefer sleeping with an eye shield, like a cartella or something, when they go to bed, so as to avoid microtrauma to the eye.
Yeah, perfect. Of course, to take care about when we prescribe the beta blockers, to avoid when the patient has asthma or any heart bradycardia.
Asthma, yes.
Yeah. Now, do you consider punctal plugs? Actually, this is one of the main, on behalf of you, I'm going to answer. This is one of the main malpractice, actually, because we are pulling the toxins over the ocular surface.
Yes, absolutely. This is a big no-no. Absolutely. Yeah. I always say if the bathing solution is sick, please don't keep it around. Just خليه يتصرف يعني. So.
Yeah. Do you use the cyclosporine?
Yes, of course, definitely. Shall I talk about it when I just discuss the management? This is just.
Okay, sorry.
Yeah.
Cycloplegic. I read it mistakenly. Cyclosporine. No, it is. Do you prescribe cycloplegic agents to relax the muscle,
Not
for pain,
all
for something?
Not all the time. Now, there's a very big difference between the pain that comes from a epithelial defect and causes the ciliary muscle spasm, and that we use cycloplegic agents to relax the patient, and the pain that comes from the ulcerative keratitis because of the keratolysis. And if you ask the same patient in two different eyes, one eye has an epithelial defect due to, let's say, herpes, or an epithelial defect due to PRK, and the other eye has a PUK, which eye hurts you more? He will definitely point to the eye that has an epithelial defect that's scratched away the epithelium. So this is the time that I use a cycloplegic agent. Now, usually in patients with peripheral ulcerative keratitis, I try to be as minimum as possible with using topical agents, because the more modest you are in using topical treatment on the eye, the more you give it a chance to just to heal. يعني بيعطيها نفس. So they're usually not screaming from pain unless the cause is a Canthamoeba, or the cause is an infection, like a staphylococcal infection, keratitis. That's the time when I give them cycloplegic agent. Usually when you start lubricating the patient and you give a pulsed methylprednisolone, the pain just is tolerable right away. It will go down to 1 or 2 out of 10, and the patient will be happy. You don't see a patient with PUK screaming unless the underlying cause is really painful.
Okay, great. So go on, Dr. Nancy. Thank you.
Okay. We were talking when to immunosuppress. So we said that topical treatment should be kept as minimum as possible. Lubrication is a hallmark of the topical treatment. We do use topical steroids just in very 1 or 2 situations, and I'll talk about this shortly. Sometimes topically includes the cyclosporin, which is the Restasis. Also in 1 or 2 situations that I will just discuss. Now, the mainstay of treatment is the steroids, but sometimes we have to skip the steroids and to go for the systemic immune suppression. And this is in few situations. First, if you see that the steroid has caused a side effect and the patient is having a major side effect of steroid, like let's say the diabetes is shooting very high and it's not controlled, and if the patient is not responsive on 3 days of immunosuppression, of steroid suppression, then you have to go straight away to immune suppression. If the patient has Wegener granulomatosis, or a severe case of polyarthritis nodosa, a severe case of rheumatoid or Sjogren's, the inflammatory markers in the CRP is sky high, the patient is +4 impending perforation, and you start systemic steroids as well as systemic immune suppression. So you give like IV methylprednisolone, and you liaise with the rheumatology and immunology to start on a cyclophosphamide. These go arm in arm together, okay? Now, in cases of a progressive Morin's ulcer, and I'll be discussing Morin's ulcer لحاله on its own, because a Morin's ulcer, there are 2 types. Either a Morin's ulcer that's indolent and very benign, and this comes in the elderly people, or a very aggressive one, unilateral in the young. And if you see a Morin's ulcer that's aggressive, not responsive in a young patient, then you have to go into systemic immune suppression with steroids right away. Because otherwise they will go into perforation as fast as possible. Now, also, if you see signs of necrotizing scleritis associated with the systemic disease, or all the signs that you see in the eye, if they see that the sclera is necrotizing and there is a severe or a form of this, you go straight away into immune suppression. So immune suppression straight away if there's an aggressive Morin's ulcer, if you have a necrotizing scleritis, these are the signs that you look for, or in a case of a very active systemic disease, like referred from medicine or sometimes from dermatology, that this patient has a severe form of disease, he's admitted, and his eye looks like this. You see him in clinic, you don't wait for IV methyl to work. You just put him on a systemic immune suppression with cyclophosphamide or methotrexate. And the last thing, which is the more relaxed protocol, is that you started him on intravenous methylprednisolone and you did not see any response after 2 or 3 days, then you will consider the systemic immunosuppression. All right. Okay. Yeah. So what are the garments that we use? What are the immune suppressive agents that we use? There are a lot. I will not be covering all of them because I'm just covering the things that I use in my practice. The most common, sometimes if this is more complicated, I do liaise with the medical retina people and the immunology rheumatology for a protocol that we share. Usually what I use for my patients, as I said, it's IV methylprednisolone. If they're not responsive or they're very severe, especially in the young. By the way, the young, they present with a severe form of PUK rather than the old. Let's say because the immune machinery is still working. It's just exactly like the COVID. The immune response in the young is much more profound than the elderly, and that's why you see a more paramount response. So what I do, I put them on cyclophosphamide, especially if it's an ocular immune response. And I do cycles of cyclophosphamide. I repeat it every 2 weeks. Usually I have to obtain a baseline CBC of, the patient has to have a baseline CBC or white blood cell count of 4,000 in order to give cyclophosphamide safely. And you give it like over half an hour, 500 milligram, and you repeat it every 2 weeks for a cycle of 6 weeks. And this is the first line in systemic diseases such as systemic lupus or Wagner granulomatosis. And now, the rheumatoid, I'll go to the methotrexate usually, but the cyclophosphamide works better with most of my patients. And that's why sometimes I do keep them. If I already started them on IV methyl for 3 days and then I shifted them to cyclophosphamide, it's okay to abstain from giving oral treatment, and you just rely on the cyclophosphamide to evaluate the problem after 2 weeks. Now, these agents, what they do, you cannot expect that the ulcer will heal and that quickly, especially if there is a systemic manifestation. What you look for is that halting of the disease progression. So if the patient had Wagner, you just look for that no progression. No progression is a good sign. In rheumatoid arthritis, on the contrary, as long as you give a high dose of methylprednisolone along with the vitamin C and doxycycline, you will see a very quick response, and the epithelialization and building of stroma will be very quick. Now, the other garments that we use is methotrexate, as I said, in a protocol that's very similar to cyclophosphamide, as the azathioprine, which is the neural, the generic name, and I usually use it also for patients with, and I meant the neural, I meant the cyclosporine, I meant for patients with ejection, but it is a very mild effect. So if the patient is going into a remission, and you don't want any of the complication from these agents, you can shift to the cyclosporine orally, and you can also use the cyclosporine topically if you think that you are curbing the inflammation, and especially if it's a Morin's ulcer. You started him like on two weeks protocol of treatment, and the patient is going into a quiet phase of quietening, and the inflammation is subsiding, and the cornea is building up some tissue. You can switch into a topical cyclosporine or an oral cyclosporine, which is more tolerated by the patients. Now, if the patient comes with a very severe form that he's not or she's not responsive to any of the immunosuppressive drugs, not the cyclophosphamide, not the methotrexate, or the azathioprine, and you can see that it's ensuing and impending, going into a very fulminant case of corneal keratolysis, you can go into the biological agents. Now, although the biological agents are the third line of treatment, they are not approved to be curative, let's say. So it does not mean because they're the third line that they're the best. No. And between brackets, they are the most expensive, by the way. They're very expensive. And we go to them because we have depleted all the resources. But sometimes kicking in anti-tumor necrosis factor, which is infliximab, which can curb the systemic disease, adalimumab, that I've never seen in my practice. I've seen the infliximab, I've dealt with infliximab and rituximab. In non-responsive cases, just kicking in this biological agent can also curb the inflammation in unresponsive cases. This does not mean that it is superior option, but sometimes this addition of a biological agent works better on some patients and not on others. So this is just to know. Now, it's very important to remember that if the cornea heals, this does not mean the end of the treatment session. These patients are chronic patients. They are frequent visitors for the clinic. They will come visit you every month just to make sure everything is fine. And you have to tell them there are good days and bad days. It depends on the immune response. Very important to boost the immune system by multivitamins and changing the diet, the lifestyle of these patients in order to curb any flare-up of the disease and any effect on the cornea in the future. And sometimes you have to go with therapy as long as 6 months if the disease is systemic. When we talk about corneal problems, we're just talking about the time you need just to heal the cornea and to take off the offending agent. That's it.
Yeah, perfect. Any further protocol? Surgical role. Now, before that, doctor. Now, let's assume that I am a general ophthalmologist. Mm-hmm. Okay, and maybe I don't have an access to such protocols. I cannot apply them. I have no experience with them. I don't know how to monitor the patient systemically. So what I'm going to do, I will share for example, the rheumatologist or the specialist in immune diseases, mm-hmm. and he will put the protocols and I will monitor the eye.
Absolutely.
Right? So yes. When I want to refer the patient to that specialist, what I understood now that there are two factors to determine which protocol, how intensive the therapy will be, which are the age of the patient and how severe is the PUK, right?
Mm-hmm. Yes.
So when I want to refer, what I am going to write in a letter to that specialist, which will guide that specialist to the best protocol to the patient. As a general ophthalmologist, I'm talking about general ophthalmologist.
Yes, that's very important actually, because this is what's been going on. This is how we practice most of the time. Your input should be your examination. You should examine the patient very thoroughly and put your input about what do you think this is. Now, the moment you decide to refer this to an immunologist or a general medicine, let's say, this means that you have excluded the local ocular causes. This is very important because you have to, it's not justified at all to put the patient through a dilemma of immune suppression for a local cause. So your role as an ophthalmologist is to exclude any local ocular cause of the disease. This is first. The second thing, if you need assistance with the what kind of tests, because I'm sure nobody of us can memorize all the tests, the immunological tests that we need, and which test for which disease, then you can just ring a doctor or a consultant about, I'm suspecting PUK and I need to run general tests. He can advise you about this. Let's say this before sending the patient over for any treatment. Now, the tests came back and there are some positives and negatives, and you suspect this is going into, let's say rheumatoid arthritis is rheumatoid arthritis. No two doctors can argue about that. Now, the more difficult is, SLE sometimes can be elicited easily. Let's talk about the more difficult polyarthritis nodosa or these vasculitis. Now, it's very important to differentiate between an autoimmune disease that's like ocular psychiatric pemphigoid, that is indolent, an aggressive vasculitic disease like Wegener granulomatosis. Why? Because one is very aggressive and might ensure into severe complications, and the other is just indolent. And now, if you were a little bit lazy or you delayed the management, it's fine. It's okay until you make up your mind or the patient makes up his mind. Now, you send the patient or you consult the internist or rheumatologist or immunologist if you have a high index of suspicion for a vasculitic disease, or the patient is in a very aggressive form of peripheral ulcerative keratitis, And usually you see the very aggressive form in the young, not the elderly. And the patient is not responding to your pulse steroid. These are brainstorming for you that this patient is going down a slope, and you have to save the body or save the eye. And usually when the patient comes with the severe form of peripheral ulcerative keratitis, it is because the disease entity, the systemic disease entity, is already attacking his body in an aggressive way, and he needs intervention. So you write this to the physician. This is a patient with peripheral ulcerative keratitis. I've excluded any ocular cause. I think the input of "I think" will lead him into which protocol to go. I think this patient might have an element of systemic vasculitis, and I leave it to you to decide for your own immune suppression protocol. That's it. He might send him back to you for a checkup after a week or 2 weeks or so. Now, sometimes you do have a conflict between us and the rheumatologist. If sometimes I might think this is a patient, if the patient is referred to me from an outside clinic, and he's already diagnosed, like for example, this is a patient of ocular psychiatric pemphigoid, and he's already on methotrexate, and they think that the patient is not improving, and they want me to check him. And when I see the patient, I think that this is I don't think that methotrexate is the treatment of choice. I think cyclophosphamide works better on the eye, maybe not on the body, but it works better on the eye from my experience. Sometimes we go into arguments, and at the end we say, okay, let me just try the cyclophosphamide. If the patient improves, then you'll go my way. If the patient does not improve, you will go your way, and we'll add a biological agent. And this is sometimes how we do. Because remember, taking a biopsy is not always favorable in a patient which is inflamed. Taking a biopsy is not favorable in scleritis. Taking a biopsy is not favorable in a patient with ocular psychiatric pemphigoid. A patient with vasculitis that can ensue a fulminant vasculitic event in the sclera is also not something you want to do. So leave the biopsy aside unless you want to take it from somewhere else to prove your diagnosis. So this is not a disease entity. We all have a clear-cut mind about it. It's okay to have a decision and then change it according to the circumstances. So don't panic. The most important thing, stop the steroids if you're already started. على الأقل, don't reach with your patient to a level of perforation while he is in inflammation. Don't let him perforate while the eye is inflamed, because otherwise you cannot do anything at that time. At least keep him plateauing until you decide which way to go. So this is maybe my message to most of the eye doctors.
Perfect. Thank you very much.
Okay, I'm just trying to. It's not moving. Okay. The importance question is there a surgical role for a disease that is inflammatory in its hallmark? The question is yes. And if we understand why this happens, we know how we can at least stop it, halt it, or decrease the effect, put it in a plateau, let's say, or treat it. We all know that the problem is not in the cornea. The problem is in whatever is around the cornea. It's in the sclera, in the conjunctiva, in the vessels, in the lymphatics, in the immune mediators that's pouring in the cornea. So as long as we cannot stop it with drugs, we can stop it with knives. We can just cut away that segment of the cornea, of the conjunctiva or partial sclera that is adjacent to the area of undermining or guttering, until we reach a stage that we curb the inflammation and the guttering and the thinning. This is an option that we usually do, especially in Moran's ulceration, that is very aggressive. So resection, a local resection for a local inflammatory response. Now, if the patient is going into severe thinning, you are already controlling the inflammation. Now the conjunctiva is, the scleritis is settling, the conjunctiva looks quiet, the eye looks less aggressive, but still the cornea is +3. And it's on the verge of perforating. Then can you do something? Yes, we can. We can go in and patch it. Patch it means augmenting the tissue. adding some more tissue in order to make it more or less fragile or less weak. We can put a corneal graft, patch graft. You can put an amniotic membrane graft. Now, the good thing about amniotic membrane is that not only it gives us growth factors and like the insulin-like growth factor and nutrition and a matrix, a cellular matrix for the keratocytes to grow into. It is anti-scar formation and it helps in the healing mechanism. So this is very important. Now, if the eye is inflamed, the amniotic membrane will dissolve in 1 week. If the eye is quiet, it will stick there for 2 to 3 weeks until the eye recovers its potential to heal. You can put a conjunctival graft. I don't like this option, but I have to mention it because the conjunctival graft means that you have invited the vessels into the cornea forever. And you're just putting this as a last way resort and nothing else. You have a poor prognosis about this eye, and you're putting a conjunctival graft. It's like a last man standing option. So I don't like it. If you have a minor perforation that's like 1 millimeter, 2 millimeter in size, and it is discrete, you know where it is, you can just glue it. And I've already, in one of the suturing series, I've already mentioned how we do the gluing technique. And this is exactly the same. You have to make sure that the eye is not very inflamed to glue. We go into the Meller graft, which is a part of the sclera. It's a part of the cornea that we take in order to cover the defect and enforce the stroma. And last but not least, if there's a big perforation melting, then or the keratocytic effect is very large and you cannot control it, then the solution is to do a penetrating keratoplasty that is full thickness. And it's very important, if you want to perform a penetrating keratoplasty on a patient who has a peripheral ulcerative keratitis, it's very important to do a 360 degrees periotomy to remove the conjunctiva away from the new cornea and to make your new cornea as large as possible, because you want to replace the one already invaded by inflammatory mediators and to replace it with one that's new and fresh, and to move away the conjunctiva, the hostile conjunctiva that is attacking your tissue. I think there are 10 comments just beeping in the. Let me check this before.
Yeah, I'm following them, Dr. Nancy. No, yeah. So no worries. You can go on. Whenever I find it suitable, I will.
Okay. Yeah, this is for the surgical room. I'm not sure what it. Yeah, there's something else we need to talk about now. Moran's ulcer. I know for sure that a lot of people or a lot of ophthalmologists have a problem with Moran's ulcer because they cannot just diagnose it. And there's always a problem during examination to differentiate between Terran marginal degeneration and Moran's ulceration, as if it makes a difference. And I'm just telling you, it's not important to know this is a Moran's ulcer or not, as long as you know this is a peripheral keratitis that you need to treat in the way properly. Now, if you reach diagnosis of Moran's ulcer, and this is to salute Dr. Moran, who discovered this in 1854. Actually, it's Dr. Bowman who appointed this entity in it was 1849, and then who published a lot of cases about it was Dr. Moran, and that's why it's called Moran's ulcer. So to salute him and not to neglect this diagnosis, it's okay to dig deep and reach this diagnosis, but it's not mandatory. Don't waste your time digging what kind of ulceration is this and start treating the patient right away. Now, let me tell you some differentiating factors between a Moran's ulceration and a peripheral ulcerative keratitis due to systemic vasculitis. First, it's a separate entity. Unlike the other vasculitic causes that are associated with an epithelial defect, this has an intact epithelium, which means it targets the stroma. It causes keratolysis and undermining and guttering of the stroma, leaving a ridge of or a flag, a white flag overlooking it. And this is what's characteristic of Moran's ulceration. And the other thing, it does not have a severe inflammation of the conjunctiva or sclera around it. There might be mild hyperemia, but Compared to the scleritis or PUK associated with systemic diseases, it cannot be compared. It's very minimal. So these are the factors that are in favor of the Morens. Now, Morens can come in so many shapes. It can come in young age, and it can come in the old age. Now, in the old age, usually it is it is bilateral, and it is it's very indolent and mild. In the young, and this is why I call it benign. In the young, it's malignant, and it cuts through the stroma so quickly, and it's progressive from the beginning. And it's the only time I prefer you use topical steroids is with the Morens ulceration. So if I said to abstain from any topical steroids in your practice with a PUK, it's all but the Morens ulceration. But you have to make sure this is a Morens before you go for the topical steroids, which is the fluoromethalone. Mild topical steroid twice daily until you make sure or make up your mind that this is Morens ulceration, because it curbs the inflammatory response so quick. Topical cyclosporin is also a very added value in this kind of inflammation, because it is a topical inflammation. It's a local inflammation compared to the systemic vasculitis inflammation. So this is a case where you need local immune markers or immune treatment in order to modify the eye's response. So fluoromethalone twice daily, lubrication is a must, and topical cyclosporin are game changers in Morens ulceration per se. Where do you see the Morens ulcer? Usually it is interpalpebral. It starts on the 3 and 9 o'clock position, and circumferential spread is very quick. The second most common is you see it inferiorly, and then it moves nasally. So these are the three most common. Although this picture, it says about superior Morin, but this is not the most common. This is what I found actually. Now, the hallmark of the disease, as we said, is the undermining of the irregularly scalloped central edge. And this is how it is described. It's an overhanging central edge or ridge that you see. You see it like a flag, and it gives you a shelf effect. And sometimes you think this is less severe than the PUK that you see with the rheumatoid arthritis. On the contrary, this is more severe. Perforation sometimes ensues so rapidly, especially if you have a young patient. Don't wait for the topical agents only to start working, and start with the immune suppression if you have a young patient with unilateral Morens immediately. Now, sometimes there are some things you have to elicit in the history of Morens disease that will guide you into the diagnosis. They are provocatives. These are what I call provocatives for Morens ulceration. Morens is a rare entity, but it's important to elicit because the topical treatment is a little bit different than the usual one. Usually, the patient has a history of herpes eye disease, and if the patient is young, eliminate or exclude herpetic eye disease. If he's old, zoster. Sometimes the patient would have been hit by a parasitic infection. And we had a patient who was a young lady who was pregnant, and she had a parasitic infection like 3 months before Morens ulceration started. And we thought this is a PUK, and we treated her as a PUK. She was pregnant. We could not add any systemic steroids. We tried the local, to mix and match local treatment, and then until we made sure this is a Morens ulceration, and we did a surgical resection of the conjunctiva in order to, and we advised early cesarean section because the cornea was very thin. She cannot go into delivery, normal delivery, because that would compromise the cornea. And yeah, we guided her through months of treatment until she had her baby in a good shape. You have sometimes trauma or surgery, especially if you do cryotherapy, it might provoke Morens ulceration. As we said, treatment is to curb the inflammation with drops. You use mild steroids, and cyclosporin has a very important factor in topical cyclosporin. It's important to remove the hostile tissue. And what I mean is resect the conjunctiva or the inflammatory to decrease the load of the inflammatory mediators that are swimming around the cornea. And we don't forget the systemic treatment. Systemic pulse steroid is very important unless the patient cannot tolerate this. And of course, never forget with the systemic pulse steroid to add anything that protects the cornea, the stomach, like proton pump inhibitors, because the patient will come with a stress ulceration afterwards, and he can sue you. And last but not least is the biological agent, not because they're more potent, but just because they add to the effect of the treatment you have already started. And I think this is all. I believe also always that know thyself, know thy enemy. 1,000 battle and 1,000 victory. So I hope this is beneficial to a lot of who are watching.
Yeah, thank you very much for the amazing lecture, as usual, Dr. Nancy. Now, is there any role to the cross-linking for in the PUK?
This is an important question. I've seen few papers talking about cross-linking in peripheral ulcerative keratitis, and I do not advise that because the cornea is already in geared up inflammatory state. We are adding a riboflavin to go into the corneal stroma. And sometimes we have patients who receive riboflavin, they go into a toxic keratopathy, which is an inflammatory response to riboflavin with UV lights. So would I just jeopardize the cornea by trying cross-linking? Actually, I wouldn't, unless in one condition, the provoking factor for PUK is infective. If I have like a fungal infection that's causing the cornea to melt and there's a peripheral ulcerative keratitis and I am losing control, then I would go on cross-link, because what I do, I'm just halting and decreasing the load of the infective microorganism that's hitting the cornea. So by that time, I can just reassemble myself, try to think, stop and think, and see where I'm standing. It gives me a very large window of opportunity. So if I'm losing control because of an infection, then I would go for a cross-linking. Otherwise, I would wait a little bit until studies would prove the efficacy of cross-linking for PUK. And not to forget something very important. PUK is a peripheral margin, peripheral degeneration. And cross-linking works in the central cornea. We avoid going into the limbus. If we go to the limbus and hit it with riboflavin and UV light, we're just killing the stem cells. So we're adding on the problem. So we don't cross-link unless maybe we take 2-3 clock hours of tissue. And if we do 2-3 clock hours of stem cells, it's fine, as long as it can be substituted. So this is my rationale actually for it.
Yeah, very good. Thank you very much. I would like to welcome Dr. Mohammed Al-Aqaba. He is cornea specialist and working in the UK. If you don't mind, Dr. Nancy, we can hear him and we can see if he has some highlights. So welcome, Dr. Mohammed.
أهلا وسهلا مساء الخير على الجميع. Thank you very much for the invitation, and I always enjoy these sort of series of lectures and enjoy listening to your talks and Dr. Nancy talks. To be honest, I don't have that much to add on. I mean, it's she mentioned almost everything related to PUK, sort of the common practice, and I just want to highlight this is an excellent point, the sort of conflict always we get between us and the rheumatologist, especially in the diagnosed cases. I've had so many cases with the rheumatoid arthritis patients. From the rheumatology point of view, they are stable, but they present to us with sort of aggressive PUK. And obviously we admit them, we start them on oral steroid or methylpred. The issue sometimes when we do the referral letter to the rheumatologist to ask them that this patient has got a PUK, it's a manifestation of systemic flare-up. They don't, most of the time, they don't grasp this thing. They don't think the eye manifestation is a sign of systemic flare-up, and they need to modify the systemic immune therapy. And we get the patients back and forth with all the referrals and saying back, you know, this patient has been always his joint problem stable, his inflammatory markers in the blood are stable. So we don't think this is something related to rheumatoid arthritis. And especially when we have a new consultant coming in rheumatology department. So what happened is we have a pack of all evidence in form of papers. We email it to the new consultant or to the new colleague to let them know, to read it through the papers and to grasp more about this complex eye problem. Most of the time we succeed. The other times we have to refer the patient to another colleague. One way I've seen it in other trusts, they do what we call a multidisciplinary, a joint clinic. They don't do it that often, maybe once a month. All these cases, like acute cases that have been seen quite frequently, we do see them together, and then it will be a really great sort of experience, because you know what they sort of questions they ask, what sort of the protocols they have, and at the same time we show them our findings and what it meant by the disease activity. Mm-hmm. So this is really an excellent clinical sort of practical point.
Definitely. Thank you for raising this point up, actually. Yes, because this is what I meant. It has to be a joint kind of cross-reference, even if it's once a month. I know that in UK, we've used to see the inflammatory diseases and the inflammatory manifestation of systemic diseases much more pronounced than in our part of the area. In our part, it's more of infectious keratitis causing these pictures. But at the end, it's all about what's in the benefit of the patient. Moving on to proving your point of view, sometimes I say, they have to see what we see in order to know what we're talking about. The patient is not a list of laboratory results. Does not mean that if the RF factor just dipped down while the eye is still angry, that I'm happy about whatever protocol he's going into. Sometimes I switch it just based on the clinical picture of the patient. If he's going okay and improving, regardless what the rheumatologist would say, I would just go with my own opinion, because at the end, he's an eye patient. And I think, in my opinion, the eye is a reflection of a mirror of the body. So as long as he's just going into a quiet phase, then I know that I'm putting him in the right direction. And sometimes a few conflict with our colleague physicians is something okay. Salt and pepper.
Excellent. And the other point is actually like here, as you said, we see the PUK actually more common than in Middle East.
Yes.
Due to this cultural thing, most of the elderly people, they live on their own. Okay, it's actually in our countries, it's a blessing, because most of our, granddad or grandpa, they live with their families, big families. So there is somebody to put the drops in for them. And these rheumatoid arthritis patients, they have joint deformities. So if you ask them to put lubricating drops every hour, in addition to maybe some antibiotic preservative-free, they won't be able to manage it. They will have difficulty. And the first few maybe weeks are crucial. So we get them admitted here in the UK. Yeah. We have nurses, they put the drops every hour for them. So that would make a huge difference for them. Maybe this is not really applied to the patients in our countries. Yeah.
I know. Before I knew this is you who mentioned the admission thing, I thought this is a practice that's done outside our area, because yes, sometimes living in sometimes in a elderly in a just isolated without anybody to help. It was a protocol to admit these patients only for installation of drops. I do remember that when I used to be a fellow, so it's just for drop installation.
Indeed. Thank you very much.
Where do you practice, Dr. Muhammad?
Well, I do practice in South Yorkshire at the moment. I practice a lot in Nottingham with the Professor Dewar.
Oh, okay. Oh,
yeah.
Lucky. Okay.
Thank you.
Fantastic. Thank you very much. I am the lucky one because I'm learning from both of you.
We're lucky to be on this platform, Dr. Thank you very much.
Well, we'll be quite honored, actually, to have you around, Professor.
Thank you very much. Now, there is a question. Which concentration of the cyclosporine do you use as topical drops? Is it the 0.1, 0.05?
0.05%, yes. Twice, sometimes I go up to 4 times daily, as long as it's in the I do cycles of topical cyclosporine, by the way. It's very important to know that if you use immune suppression drops or drugs, it's very important to go into cycles and not to maintain it monotonous all the time, because you will lose the value of immune modulation. So don't keep a patient on cyclosporine for long. I just do like 4 weeks and then I stop it and reinstall it for another 4 weeks or so. It's just cycles. boosting, making the immune system or the immune response up and down.
Perfect. There is a question from Kariman, and actually this question comes to my mind as well. Now, what's the difference between topical steroids and IV? For example, we say that we must stop topical steroids, but we can give the IV. So what's the difference in mechanism?
Yeah, topical steroids, they act as a local inhibitors to the collagen formation in the wound, which is, or the cornea or the stroma. So it inhibits the formation of collagen and the structuring of the stroma locally, topically. And that's why we don't use steroids if there is an ulcerative keratitis due to an infection. We don't use steroid infection when it starts, because we give it some time to heal, and then we kick in some steroids to curb the inflammation. And this is the same thing. The intravenous or the systemic steroids, they work on the systemic immune system. Very unlikely to reach in high concentrations the area of the cornea per se, because the cornea is supposed to be avascular. So they work mainly on the immune system of the body, modulating it and just curbing the whole inflammatory response of the body. We don't use it for a long time. That's why I said, because we don't want it to reach the corneal tissue. Unless we have a large bore vessel caliber, then it will reach in no way. So the steroids will not be of good value at that time.
Okay, I think there is only one last question. Thank you, Nancy, for answering that one. Thank you. Now, the last question is, what is the important visual impact of these PUKs in young people? I think she means after healing, maybe. Maybe we can say irregular astigmatism.
Yes, definitely astigmatism. If they cause significant guttering, but if they heal, they're in the periphery actually. If they heal well and the cornea retains its sphericity, it does not cause that much of an effect. And even the scarring would not be that noticed, honestly. And patients with PUK, you'll be amazed how the cornea heals beautifully in patients with PUK if they are just, the immune response is just stopped.
Yeah, actually, because of the epithelial masking,
Yes.
because
Yes.
we know that the epithelium has a great capacity to fill the gutter and to overcome the humps. And so it tries to compensate by smoothening the anterior surface of the cornea. An amazing capacity of the epithelium.
Absolutely.
Yeah.
And just one minor point to add in these sort of, especially if we're dealing with vasculitic disorders, please do dilate the eye. Please have a look at the eye. Just not focus on the cornea. This is a medical legal point.
Yes, yes. This is very important. Look at the patient as a whole and the eye as a whole. Yes, it's very important.
I always advise in my presentations, let's say that we have to deal with the eye as a patient, not as a disease, and not as a particular, even with a dry eye patient. How simple it is, but actually it is very sophisticated because the background is the most important to deal with. So we are talking about dry eye. So what if we are talking about an inflammatory disease?
Yes, yes.
Yeah.
Very important. Look at the patient as a whole.
Hello?
Yeah.
Yeah. So great. Thank you very much, everybody. I'd like to thank Dr. Nancy for the amazing lecture, as usual. We learned a lot of lessons today, and I'd like to thank as well Dr. Mohammed for being with us and joining us as a panelist. And I'd like to thank the audience as well for their very nice questions that, let's say, made mind-storming. In addition, I would like to remind you about the coming lecture of Dr. Nancy, which will be just after a couple of days. The lecture will be about the chemical burns of the cornea and ocular surface. That will be on Monday, the coming Monday, 5th of October. at the same time, 6 p.m. GMT time. So please be with us. And thanks again, Dr. Nancy. Thanks, Dr. Muhammad.
Thank you very much. Looking forward to it. Thank you.
Good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam.